And then we're going to record this for anyone who can't make it. And we will have time for questions at the end. So if you'd like to put your questions in the chat, I'll keep an eye on them, and then Ed will field them after his presentation. But I just want to give you a little bit of background about Consumers Council. We've been around since 1971. We were founded by Alberta Slavin and Joyce Armstrong, who is here with us today. And they were two women who noticed that grocery store pricing was inequitable in the St. Louis area. They observed that the prices in the North St. Louis grocery stores were higher than the grocery stores in suburban West County. And so they got their friends together and they researched this, and eventually they were able to pressure the grocery stores into changing their prices, and they received national recognition for this. And so that's how Consumers Council started. But as we continued throughout the years, we started focusing on utility rates, and then that expanded into banking practices, equitable banking practices, and healthcare too. So with utility rates, we scrutinize the rate increases that the utilities propose. We also do our best to expand and maintain customer assistance programs for those who can't afford their utilities. And usually when I mention utilities to my friends, people just their eyes start glazing over. But if you think about it, this is so important. This is something that is a social determinant of health. If you don't have access to air conditioning or refrigeration for your food, you have a hard time surviving, especially in a St. Louis summer. And then with the banking practices, we focus on the Community Reinvestment Act. We work to make sure that banks are lending equitably in the areas where their branches are located. And Jackie Hutchinson, who's on this call, Jackie, you want to raise your hand and say hi to everyone?
Hi, everyone.
She not only has a lot of experience in the utility work, but she also has a lot of experience in the banking work. And I'm newer to the organization. I started in May of 2021. But what I've learned is, unfortunately, some of the local and regional banks, even though they have branches in the north areas of St. Louis, their banking practices are focused in the southern areas and the west and West County. So we work to change that. And with healthcare, I'm going to let Ed tell you a little bit more about what we do in the area of healthcare, but a lot of what we focus on, again, is ensuring that there's equitable access to healthcare, and that's along the line of Medicare for all and Medicaid expansion. And we're really, really lucky to have Ed with us tonight because he is a nationally recognized expert on Medicare. Ed, he's the president of our board. He's also the National Board Secretary and Missouri Chapter Chair of Physicians for a National Health Program. After practicing family medicine for 20 years at Rush Medical Center in Chicago, he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts, which he did until retiring in 2010. He volunteered as an assistant professor of clinical medicine at Washington University in St. Louis from 2004 until retiring in 2021. He received his medical degree at the University of Illinois in Chicago in 1979, and he completed his family medicine residency and then a fellowship in family medicine education at Michigan State University. So with that, I'm going to hand it off to you, Ed.
Thanks, Sandy. And Sandy's been a real injection of energy and organization and ideas into the organization. As he has Jackie and Joyce and others. Organization's doing so great with the leadership that we have now. So thanks, and thanks for setting this up. As you heard, I retired 2 years ago, and one of my worries about retiring, although as much as I love seeing patients, one of the other worries I had about giving that up was that, well, gosh, where would I get stories from to tell when I when I give all my single payer spiels, because I do lots of discussions about Medicare for all around the country. So, and I like connecting it to things that I've experienced, as we all like to do. And I was worried, well, what would happen? Where would I get stories from? And so the good news is my friends and family have been turns out to be a pretty steady stream of things tragedies to tell you about, or stories to tell you about. So I'll tell you one that happened with my wife just a couple of months ago, and I have her permission to tell you the story in case you're wondering. So she needed to get a high resolution CAT scan of her chest. It's a fancy version of a CAT scan. She needed to get that. Her physician, I wasn't treating her, of course, for this. Her physician ordered it. I called the radiology place to schedule it. And before they asked me her name or anything, they asked me, well, what kind of insurance does she have? And I said, well, she has Medicare Parts A and B, and we have Medigap, a Part G supplement. She said, and then the next thing, again, before they asked her name, was, well, what time tomorrow would you like to come in? Hooray. So, we got her in the next day. And I said to her then, after we scheduled it, I said, so, what if I had given you a different answer to that question? What if I had said we had Medicare Advantage? And she said, oh, well, then I would have told you that we'll call you back in a week because we have to get that approved. To get that kind of a CAT scan, we have to get that approved by most Medicare Advantage plans. And that takes 5 or 6 days usually. We usually tell people a week. I thought, well, that's a good example of why we didn't go into Medicare Advantage. So tonight, let me show you some little slide here. Oh, come on, Tides. There we go. So tonight we're going to talk about this seemingly confusing topic of Medicare and the different flavors, traditional Medicare, Medigap, Medicare Advantage, what's going on with all this? What do the TV ads all mean? We'll talk a bit about that. And the first chunk of time, I'm going to tell you, frankly, some concerns I have about Medicare Advantage. I'll try to help you understand what it is, first of all, then I'll tell you some concerns I have. But let me kind of be real clear that at the back portion of this, it's not going to be as black and white as, oh, I don't want that. No, it's not. I'm not making that case. It's really an individual decision. There's pros and cons of how you want to approach your personal strategy for managing Medicare. And it's a decision, and I'll help you understand the decision because my main concern, Consumers Counsel's main concern, is that you understand the decision you make, and it's not a slam dunk. It's a this or that, but it's you need to know what you're deciding. So the slides I'm showing you are slides that I made for my other hat, consumer or Physicians for a National Health Program, but modified a bit for tonight. But it's the same slides basically that I use for them. So first, traditional Medicare. What does that mean? Traditional Medicare. So Medicare, as you probably know, started in 1965, and so it's now traditional in a sense. Some people, I call it traditional Medicare. Some people call it original Medicare. It comes in different pieces. In traditional Medicare, when I say that, or really when anybody says that, we're referring to Medicare Parts A and B. Medicare Part A, as you probably know, is primarily covering hospital work, inpatient stuff, and Medicare Part B is primarily covering outpatient office visits and testing and things like that. So Medicare Parts A and B are what I mean by traditional Medicare. It's what was established way back in 1965 and still exists and is thriving, and I'll argue to you is terrific, actually. But that's what traditional Medicare is, and it's really pretty straightforward. So there's all of us on the left. We pay our taxes, and then we turn 65 and we get in the mail that precious red, white, and blue Medicare card, and then Medicare directly pays physicians and hospitals on our behalf. It's, of course, a little bit more complicated than my cartoon here, but pretty much just that. We pay, and then they pay, and then that's kind of it. Medicare Advantage is actually phenomenally different than that. First of all, it's I would argue it's really neither Medicare nor an Advantage, but it's not run directly by the government in the same way that I showed you for traditional Medicare. Instead, Medicare Advantage is operated by the same kind of commercial insurance companies that we've gotten used to from employer-based insurance. So a lot of these outfits you see here and that I've put in the middle are the same companies as the ones that do employer-based type of insurance. So it's typically for-profit, not entirely, but typically for-profit, independent, publicly traded organizations or businesses. So they're in the middle here, and you notice that there's gaps because there are gaps between them. But basically, the way this works is that Medicare no longer pays the doctors and hospitals if you go into Medicare Advantage. Instead, Medicare pays the insurance company. They pay the insurance company actually a fixed dollar amount every month, I think it is. Maybe it's every quarter, but they prepay them for anybody that's signed up for their insurance company. So Medicare itself, the federal government no longer pays the doctors and hospitals directly. Instead, they pay an insurance company to deliver your healthcare benefit, and then the insurance companies contract with the doctors and the hospitals. So although right off the top, you can see that it's far more complicated, and complexity tends to be expensive. And I will prove that point to you. But you can see it's a bit more complicated, and it's yet at least one more level complicated because they don't want you to go to all those doctors. The insurance companies typically say you can go to this doctor, but not that doctor. You can go to this hospital, not that hospital. So it's Medicare doesn't do that. Medicare covers virtually every hospital, and I think 89% of adult medicine physicians around the country accept Medicare as a form of payment. 96% of surgeons accept Medicare as a payment. You can't if you're living in Missouri and you're going for a vacation, or you're living for 3 months in Florida for some reason, and you have Medicare Advantage. With most forms of Medicare Advantage, if you go for 3 months in Florida and you have anything other than emergency care, they won't pay for it, or they'll pay much less for it. So the networks tend to be much more narrow. So it's fundamentally different from Medicare in all of those ways. And the one I just said was the smaller networks. They're lists of doctors and hospitals. And also they have the ability, the legal authority, to do these sort of HMO type style tools that some of us have gotten used to in commercial employer insurance, but we all kind of dread, where you have to ask permission for things. You have to get prior approval, like that chest CAT scan that I was talking about. So they get in the way. They intervene. Traditional Parts A and B Medicare almost never does that. They almost never ask for prior auth. I think there's like 6 cosmetic procedures that they prior authorize. Otherwise, if it's a prior authorization going on, it's Medicare Advantage and not Medicare. Medicare doesn't get in the way of those decisions. So because the Medicare Advantage company is paid on a quarterly basis, I think it is, for everybody that's in there, and then they have to pay for your doctor and hospital visits, well, then the more they have to pay for doctor and hospital visits, the less money they can keep as profit. And the less they have to pay, the more money they can keep as profit. So if you're really sick, they're not eager to have you as a member, frankly. And if you're particularly healthy, they do want you, which is why the ads on TV show people literally rock climbing in their Medicare, or bouncing on a trampoline to try to attract those folks into Medicare Advantage. They don't show you somebody on a ventilator trying to get. So they don't want you too much if you're sick, and they do seek you out if you're healthy. Because of this and some shenanigans I'll show you, they have particularly generous profits and remarkably high overhead, and I'll show you some data about that. And then lastly, these are for-profit businesses typically, and they have extensive accusations of fraud and fines for fraud, and settlements with the federal government for fraud. So there's some pretty unpleasant business going on there. What is the business of Medicare Advantage? Well, the first thing, as I sort of alluded to, is that healthcare, the actual paying for healthcare, is a liability. The more healthcare they have to pay for, the more expensive it is, and the less profits they can retain, which means that the sicker you are, the less they want you, which also means if you're really, really sick and you want to go someplace out of network and they won't let you, and you complain, they'll say, well, that's what you bought. And you'll say, well, I'm going to quit. I'm going to go out of this program. That's actually the business strategy. That's not a problem. They're not unhappy to have you do that. That's called lemon dropping, because at that point you're a sour lemon. And then likewise, they're paid for the average person. So if they can attract somebody who's healthier than average, that works out to their advantage. So those are 2 strategies called lemon dropping and cherry picking. And then lastly, they want to rack up as many diagnoses for you as they can, because that's determines how much Medicare prepays them. So if you've got a whole bunch of diagnoses and look really sick, they've worked out the system so that means that Medicare pays more for you than if you don't have any diagnoses. And they do this a lot. Here's some new data that just came out, I think, a week ago, that shows that if you're in Medicare Advantage, almost 1 in 5 Medicare Advantage patients get a home visit, typically from a nurse. And that's pretty uncommon in traditional Medicare. So they send a nurse out to your house. But notice they only send one nurse out one time, a single home visit. That's very common in Medicare Advantage. Whereas for ongoing home care, it's much more likely that you're going to get that you'll be getting ongoing home care from traditional Medicare. So traditional Medicare will send home care to you if you need it. Medicare Advantage will send somebody out more likely just the once. Why would they do that? They do that because sending somebody out to your house once gives them the chance to record diagnoses that even your physician didn't bother to record because they don't have any medical value. They're not something that anybody is going to be treating. But if the MA company can send somebody to your house, I'm saying MA for Medicare Advantage, but if the MA company can send somebody out to your house to find out that you've actually got something that's of no clinical importance, then they can add that to your record that they submit to Medicare and justify getting paid more to have you. So they'll come out and see you once. That they do a lot, but they're much less likely to actually give you ongoing home care. And just this one game results in billions, tens of billions of dollars every year that are just getting drained from the Medicare trust fund. Just that one game without adding any real clinical value. And indeed, the Kaiser Family Foundation reported that Medicare Advantage has never saved money for traditional Medicare. And in fact, it just costs more money. Is it a lot? Well, just look at the overbilling and look at the dollar amounts that I'm telling you. The dollar amounts for the overbilling from Medicare Advantage are larger than the entire National Aerospace Program, larger than the Children's Health Insurance Program, larger, significantly larger than the entire Federal Bureau of Investigation or the prison system. I mean, so it's hard, when you hear billions of dollars, it's hard to figure, is that real money? Is that important to a thing as big as well, yeah. We fight over these other things, and yet we're just sort of turning a blind eye to how much Medicare Advantage companies are pilfering. And it turns out that it's pretty expensive to run these systems. So if you just look at the SEC filed reports of the overhead for these companies, and that's overhead and profit, that's the money that's not being spent on actual healthcare. It's, let's say, about 15%. Is that a lot? 15% overhead and profit a lot for a business? No, in some businesses, maybe it's not, but in healthcare, it turns out it actually is. It turns out that traditional Medicare parts A and B, which have the sickest patients in the country, frankly, because they have, seniors, they're the sickest patients in the country, they operate with a 2% overhead. So it's a pretty big overhead difference. And it's not magic, right? The Medicare Advantage companies advertise on the television. They, you see all those ads, they have massive sales and marketing forces. They have, I said that they prior authorize things. Well, somebody has to man the phone, has to staff the phones and get in the way. So a lot of business, but very complicated information systems and such, they have a lot of reasons to have overhead that traditional Medicare doesn't do any of that stuff. They don't, they don't do any of that stuff. So they can easily work with less overhead. And perhaps more worrisome, MA plans really do get in the way of your care. So as I said, traditional Medicare doesn't do this hardly at all. Whereas if you look at the percentage of Medicare Advantage patients who have to get prior authorizations for things, it's huge. It's huge. Try to get chemotherapy, and 1 out of 100 MA patients can get chemotherapy without having to go through that. And you're sick at that point. You've got, if you're not physically debilitated, you've got stuff on your mind, and the last thing you want to do is figure out how to jump through hoops. So this is a problem that's rampant in Medicare Advantage so that they can save money, and just doesn't exist in traditional Medicare. And they can do these things with their own secret rules. They can deny care with rules that they make up that are not the same rules that happen in traditional Medicare. It's been looked at, would have approved 18% of the time that a Medicare Advantage company denies a claim, it would have been approved had you been in Medicare, had you been in traditional Medicare. Okay, so that's an average. 18% is an average. So some Medicare Advantage companies are probably better and worse. There are some that probably have, let's say, a 40% inappropriate denial rate, and some that maybe only have a 5% inappropriate denial rate. And if I were picking a Medicare Advantage firm to join, I would want to pick one that was better about this. You can't. That data is housed within Medicare, but they don't report it publicly. You cannot find out the specific denial rate, even though Medicare knows it. They've been banned from releasing that, and you cannot find out the actual denial rate. So you can't shop for the Medicare Advantage company that's less intrusive in your care. You can't. We have, rumors about it, but you can't shop based on that. And this is meaningful. This is meaningful. If you get an obscure kind of cancer, and you want to go, if you have an appendectomy that you need, probably any community hospital is just fine. But if you need one of these things that I put on this chart here, you need your esophagus, removed. If you need one of these things, you want to go to one of the best places that you can. And with traditional Medicare, you can. With Medicare Advantage, there's a good chance you won't be able to go there. There's a good chance that you won't be able to go there, but yet you would have been able to go there. And this is, you sign up for this stuff when you're feeling healthy and well on Monday, and on Tuesday, you find out you've got some dreadful disease, and you're stuck, as I'm going to show you. And that's why people in the last year of life who are most likely to be sick, the year before they die, are most inclined to want to leave or to leave Medicare Advantage if they can. And the main reason they want to leave in the last year of life is because they have difficulty accessing the specialized care that they think they need at the last year of life. So why do you join it? You join it because of these perks that they say they have. The ads on TV all talk about dental care, that includes dentistry in Medicare Advantage. This just came out a few days ago, yesterday, I think, actually, that shows that people in Medicare Advantage, despite having a dental benefit, typically, I think they almost all have a dental benefit, are less likely to be able to go to a dentist because of cost than are people who are in traditional Medicare. Because it's a benefit. The dental benefit is good enough they can advertise that they offer it, but it's crummy enough that it doesn't actually help you much when you need anything more than the most minimal of dental care. They supposedly have this advantage, and yet they have barriers to all kinds of care. So across all income spectrums, people in traditional Medicare describe themselves as having fewer cost barriers to care. And if you look at low-income people, and this is what really gets my goat, if you look at people who are less than 200% of the poverty level, which is pretty low income, if you look at that group, they're even more. They're also more unable to get care because of cost. And the reason that this particularly incenses me is because the Medicare Advantage companies promote themselves as a solution to the problems of racial and income inequities, and that's just not the case. So if you look across racial groups, if you look across the whole country, cost-related problems accessing care, Medicare Advantage people describe a lot more problems accessing care. The numbers are smaller, but still pretty significant for whites, and a little worse for Hispanics, and for African Americans, it's the most egregious. And it just drives me crazy. It just drives me crazy that whenever I talk to congressional staffers, they tell me that the Medicare Advantage firms are telling them that they are the solution to equity in the United States. But all of the data points in the other direction, that they are the symptom, not the solution of the problem. Same thing is true for medical debts and medical bills. If you're in traditional Medicare, you're much less likely to have medical debt or medical bill problems. Maybe you'd say that it's lower income folks who are in Medicare Advantage, and maybe that's kind of influencing that. Well, that's not really the factor. Even among lower incomes, there's more trouble if you're in Medicare Advantage. Medium income folks, between I think 200 and 400% of poverty was what that was defined as, have even more problems if they're in Medicare Advantage. The only group that doesn't is the wealthy group. So higher income Americans don't have as much trouble from Medicare Advantage in terms of cost barriers. It's not a solution to equity. Medicare Advantage does not address the equity problems in our country. And we all see the ads on TV, right? Well, the Senate Finance Committee in I think December last year did an extensive review November of last year, did an extensive review of marketing procedures within Medicare Advantage, and they found all sorts of things like this one. and you probably got something like this in the mail. It looks like it's a tax form, right? It looks like it's a tax form. And so you get one of these, and most of us look at that and think, oh, I better fill it out. It's I don't want to get in trouble with not filling out my tax forms. So you fill it out and you send it in, totally unaware that it's not a tax form. It's got nothing to do with the federal government. It's an application to join Medicare Advantage. They're tricking you into joining Medicare Advantage. You don't see that. You have to really read carefully to kind of figure that out. So I'm going to say some things about insurance agents, and I need to caveat that with pointing out that I know some spectacularly good insurance agents. I know one in particular whom I would literally trust with my life. He used to be my physical trainer, and I would literally trust him with my life. There are people who I have an incredibly high opinion about insurance brokers. So I'm going to tell you some things about insurance agents, but I don't want to say that that's everybody. But you need to know some things about this. So how do you figure out, are you going to go to Medicare Advantage, or are you going to go to stay in tradition? How do you figure this out? And I'm going to give you some tools at the end for how you can figure it out. I'm going to show you how you could figure it out and avoid this trap. But about a third of us trying to make that decision call up an insurance broker. And like I said, there are some really good ones, but call them up, and then they'll give you advice. And they'll usually say, hey, I'm agnostic. I sell every product. I sell all the insurances. It doesn't matter to me which one you buy. I'm just going to look out for you. Let's sit and talk, and I'll give you the best one for you. Sounds nice. They don't tell you this. They don't tell you that they're going to make a $500 commission. It's probably higher now. I don't have newer data. They don't tell you they're going to make a $500 commission off of you if you sign up for Medicare Advantage. And it's a commission that repeats every year. I think it gets a little bit smaller year by year, but it goes on for like 10 years, I think is the number, as long as you don't change. If you don't change insurance or change brokers, they keep getting this gravy train every year from you. So they might call you, and say, hey, how you doing? How's the kid? Something, for, a minute, and be nice. And, you want the same thing? Yeah, I want the same thing. Okay, yeah, great, fine. See it, and you've renewed. So big money for them to sign you up for Medicare Advantage, and not so much money if you sign up for Medigap. I'm sorry, that's a conflict of interest that they should disclose to you. They don't. They make significantly more money if they steer you towards this decision against it. And then if you ask them, can you help me figure out my Part D, my drug benefit? They'll say, oh, no, that's really easy. Just go to Medicare.gov and look for the drug benefit, and you can figure it out. It's easier to figure out your Medigap plan than it is to figure out your Medicare Part D plan. Your Medicare D plan, those are kind of intricate and complicated and confusing. Medigap is really simple. So if they're thinking that they can just send you to the Medicare.gov, which I'll show you in a few minutes, to do your Part D because it's so simple, well, why don't they tell you the same thing for their entire book of business and Medigap in particular? Well, they don't, because they stand to make a bigger commission if you make one decision versus another. So use the tools I'll show you at the end before unless you really have to use an insurance agent. And I hate to tell you, and I'm sure that my friend who's an agent doesn't do this. I'm sure he doesn't, because I know him. He's a person of honor and repute. But I will tell you that that Medicare, CMS stands for the Centers for Medicare and Medicaid Services, CMS, Center for Medicare and Medicaid Services. They took one of the M's out, so it's just CMS, not CMMS, but CMS basically is Medicare. And Medicare last year did secret shopper calls of insurance agents and concluded that 80%, all basically, 80% of the secret shopper calls were inaccurate or insufficient. And my personal favorite, because I spent years working in the pharmacy benefit world, is this blatant lie. You call them up and you say, hey, what if I'm looking at your Part D plan, and I want your Medicare Advantage plan that includes a drug benefit, and my drug isn't on the formulary. Agents say things like this: well, if your drug's not on the formulary, don't worry your pretty little head off. Don't worry. Your doctor will just call the health plan, and the health plan will add the drug. This does not happen. This never happens. I mean, it never happens. It's a bold-faced lie just to get you into what they want to sell you. And we've seen all these ads, they're all over the TVs, tis the season to be Medicare Advantage, I guess. And you've seen them. I want to point out a couple things about these ads. The first thing is they look like they're from Medicare, right? They've all got that little red, white, and blue Medicare card in them. They have nothing to do with Medicare. They are not from Medicare. Now, supposedly this year, they're changing that, and Medicare is going to be pre-approving all the TV ads for the first time ever, and is going to put more constraints on when they can actually use the image of the Medicare card. But they don't actually have to use the image of the Medicare card. They can just make a red, white, and blue looking image, and we'll still think it's Medicare. But this is not Medicare, despite the cards when they show you. And they've got a phone number, and the phone number, like call 1-800-Medicare, or call all these numbers that are on the card, and they look like they're calling Medicare. You're not calling Medicare when you call those numbers. You're calling an insurance broker. You're calling an insurance company. You're calling a data miner. You are not calling Medicare. Do not call the phone numbers on those ads on TV, and I'll show you who you should call. Okay, so I warned you that I was going to kind of tell you some problems with Medicare Advantage before we show you that it's actually not a slam dunk and you have to make a decision. So if there's all these problems, why now 51%, I think, of people in Medicare are in a Medicare Advantage plan? It's now the thing. Well, the reason is Medicare is imperfect. It's imperfect. It has three major flaws. The first is it has a 20% outpatient co-insurance. So if you don't do anything and you go for outpatient care, you got to pay for 20% of that. Well, if you go to a doctor once a year and it's $100 visit, you'll pay $20 once a year. It's not a big issue for most people. If you are pretty sick and you're going to the doctor 2 or 3 times a week, that 20% co-insurance can bankrupt you. So that's a problem. Second thing is if you're hospitalized, the hospitalizations have a deductible now of $1,600. Hospitalized once, that's enough to bankrupt many people. Hospitalized 2 or 3 times a year, not very many people can afford that kind of a deductible. So again, bankruptcy. And there's no limit on this. These dollar amounts add up without limit in traditional Medicare. And you have to pay a premium, right? So no matter what you do with Medicare, you really want to pay the premium for Part B. But if you're in traditional Medicare and you want to get pharmacy coverage, you got to pay a premium for Part D plan, D for drug, and you have to do something. Maybe if you're staying traditional Medicare, you probably should get a Medigap plan, which, as I'm going to show you, just basically gets rid or almost gets rid of the copays and deductibles. So it's really important protection. So if you stay in traditional Medicare, you really want to get Part D and the Medigap plan. You really have those 3 options. So you can just keep traditional Medicare and not do anything and risk significant risk of bankruptcy, or you can leave traditional Medicare and sign up for Medicare Advantage, which I've shown you has some flaws, but some concerns, but we'll get to some more opinions about it. Or lastly, you can keep traditional Medicare and purchase Medigap. Those are your choices. Do nothing, go to Medicare Advantage, or purchase Medigap. But notice I said maybe purchase Medigap. Maybe. There's a deal with this. So we've kind of gotten used to the idea of no pre-existing conditions being considered when you try to buy an insurance product. Before the Affordable Care Act, you try to buy health insurance, and the insurance company would send you a questionnaire saying, hey, have you had this? Have you had that? What have you had? What drugs do you take? All this, they would, and if you were sick, they wouldn't sell you a policy, or they would sell it to you really expensive. And the Affordable Care Act made that illegal. The Affordable Care Act made that illegal. So now when you go to buy insurance before you're of Medicare age, you go to buy insurance and they can't send you that kind of a questionnaire. That's gone. Pre-existing conditions are not a thing. It's protected federally. So we think that that's the case for everything, but it stops at age 65. It stops when you go into Medicare. So when you go into Medicare, Part B specifically, the first 6 months that you're in Medicare Part B, and you try to apply for a Medigap policy, you still have that protection. It's a different law, but you still have that protection. So the first 6 months that you're in Medicare Part B, or Medicare basically, and you try to buy a Medigap policy, they can't send you a survey about have you had the whatevers. They can't send you that. They can't ask for your medical claims. They can't do any of that stuff. You apply for a Medigap policy when you're in Medicare Part B, and they have to sell you a policy at the same price they would sell it to anybody else in your community. So that's called guaranteed issue. It's guaranteed they'll give it to you, and community rating, because it's rated at the same price as the community. So the first 6 months you're in Medicare Part B, or that extends to the first 12 months when you're kind of trying out Medicare Advantage, is how I think they call it. So, but after that, after those time periods, if you're in Medicare Advantage and you run into one of those network problems, you're in Medicare Advantage for 4 or 5 years, things are going great. You had your appendectomy, nobody got in the way. You got your whatever treated, nobody got in the way. And then you get something bad and you want to go to the specialty hospital that's not in your insurance company's network, and they say, no, you can't go. And you think, well, if that happens, I'll leave Medicare Advantage. I'll have saved some money and I'll leave them and I'll go back to traditional Medicare and I'll buy a Medigap policy. No, you probably can't do that. After 12 months, in most states, including Missouri, you have no guarantee that you can get a Medigap policy after you've been in Medicare Advantage for 12 months. So it seems like you're making an easy financial decision and not realizing that it's permanent. You might be permanently trapped there. Actually, this is the thing that's been coming up lately. If you're in that circumstance, you really need to leave Medicare Advantage and you're willing to take extreme measures, you can sell your house and move out of state. Because if you move out of the service area for your Medicare Advantage plan, remember these things are regional. It might be like only in Missouri, or if you move outside of your service area, you have to actually move. You can't just get a mailing address. You have to actually move. If you move out of your service area, that triggers what's called a special enrollment period. Like open enrollment, you've heard, that triggers a special enrollment period. And then all of a sudden you have the protections for Medigap. You can go back to traditional Medicare and you're guaranteed that you can buy Medigap. So easy problem, just, move. And there are some brokers that actually in extreme cases will recommend this. I've heard stories about this. Okay, so why do people do this? Why do people sign up for Medicare Advantage with all these problems? Well, let's look at these two things side by side. So I'm going to compare a Medigap and specifically Plan G. There's a few of these, but almost everybody should, if they're looking at it nowadays, would be looking at a Plan G. So we'll focus on that. And for the most part, you can forget that there are other choices, but for Medigap, for the most part. But Plan G versus Medicare Advantage, or MA, which is technically Medicare Part C. So we'll look at Plan G versus Part C. We'll look at Medigap versus Medicare Advantage. So Medigap plans don't give you any extra benefits. They don't cover anything beyond what's covered in traditional Medicare. Medicare Advantage, as you know, often includes extra perks, a pharmacy benefit almost always, hearing, vision, pharmacy benefit with prior authorizations and step therapy, I might point out, hearing, vision, dentistry, and these things are inexpensive. They attract the healthier people. In general, they're worth just a few $100s in total when people actually get to using them, but they do come with extra benefits. Medicare Advantage has extra benefits. Medigap does not have that. So on this line, Medicare Advantage is the winner. They're better than Medigap. Out-of-pocket costs. You have no out-of-pocket costs after you've gone through the deductible in Medicare Part B. You have no out-of-pocket costs when you're in a plan, when you buy Medigap. Zero out-of-pocket costs after you go through, if you have Medigap, and once you go through the $226 deductible. Medicare Advantage, it's a little bit different. They can charge you copays and deductibles and whatever, nonsense they want, as much as $12,450 if you go inside and outside of network, or $8,300 in network. So some Medicare Advantage companies use smaller numbers, but the federal limit for them is as high as more than $12,000. Again, zero with Medigap plan once you hit the deductible. So I think out-of-pocket expenses, which nobody thinks they're going to have, but they do, out-of-pocket expenses, Medigap is hands down and away the winner. Utilization management, that's the step therapy and the prior authorizations and all this stuff that we know and hate. That's rare in Medicare, in traditional Medicare, and Medigap plans do not add any new step therapy or prior. They don't add any utilization nonsense. They don't get in your way. And Medicare Advantage is rife with that. So at that point, I would say Medigap is the winner. Networks, Medigap has the whole network. Like I said, 89% of adult medicine physicians around the country and 96% of surgeons and virtually every hospital. I'm saying 89%, but not all of those 89% are taking new Medicare patients, because not all of that 89% are taking any kind of patients. But overall, anywhere in the country, the vast majority of physicians and Medicare Advantage, absolutely not. They tend to be regional, local. They're highly variable, and they tell you, and it can change mid-contract. You can sign up for a year, and then 6 months in, Dr. X is no longer in their network. So for that, I would say Medigap again is the clear winner. Monthly premiums. So whether in Medigap or Medicare Advantage, you're typically going to pay the $165, I think, is the national average for Part B, which I said Part B, the outpatient stuff, you really would be silly not to get that $165. You need to get that for Part B, and you need to pay that whether you're in Medigap or no Medigap or Medicare Advantage. Medicare Advantage companies will sometimes claim that they will pay your Part B premium for you. Nice, give you money back on your Social Security check. It's rare. It's very uncommon. It's, I think, less than 10% of companies. They all advertise that they can do it, but they do it, I think, in less than 10% of the time. So basically everybody pays the $165. If you're in Plan G, then I think the average nationally is about $200 a month for that. And then the national average, I think, for a Part D drug benefits, another $32. So if you're in Medigap with Part B as well, you're going to look at $4,700 a year that you're paying in premiums, basically. If you're in Medicare Advantage, you still have to pay the $165 for Part B. The national average is $15 for Medicare Advantage per month, although in Missouri, a lot of them are free. So, but the national average is $15. So, and it includes a drug benefit, so you don't have to purchase a drug benefit. So you're looking at, let's say, about $2,000 a year. So there's a cost difference here, right? Medigap plan is about $4,700 a year, all told, and Medicare Advantage is about $2,000. So what's that? About a $2,700 difference. And for a lot of folks, depending on your income level, that $2,700 a year difference is determinative. That's how you make that's as far as you can look. But I would urge you to also look at what happened. That's if you don't get sick, right? That's before you use the thing. That's if you don't get sick. And if you're not going to get sick, if you got some secret sauce that keeps you from ever getting sick, well, you don't need any of this stuff, right? But if you are going to get sick, and I promise you, nobody gets out alive. If you are going to get sick, you need to look at that second line, that zero out of pocket after you buy your deductible versus, so you're paying about $2,500 to eliminate the risk of that $12,000 out of network, the maximum. It's a decision, and that's why I'm saying that it's a decision. It's $4,700 for one approach, and it's $2,000 for the other approach. But it's less black and white depending on how sick you might get. But if you don't know about that trap I told you about a minute ago, a lot of seniors going into Medicare, or people in Medicare, traditional Medicare, who see the ads on TV, see that they can save some money, and they think, well, I'm going to start with Medicare Advantage. It's $2,700 less per year. I'm going to go with that, and I'll go back to traditional Medicare if the MA plan will let me see who I need to see, because it is true that you can go back from Medicare Advantage to traditional Medicare whenever you want. I think during open enrollment season, but once a year, you can go back to traditional Medicare if you want to. But they don't know what's not true, which is also true, which is that you're trapped because if you can't get a Medigap policy, you're going to go bankrupt. You're risking bankruptcy exposure if you get sick and you're interested. So you need Medigap, which means you need to buy Medigap the first 6 to 12 months that you're in Medicare. You can't try out Medicare Advantage for 2 years and then count on being able to go back if you didn't like it. Okay, a lot of information. How can you actually get somebody to help you? I told you that insurance agents are not consistently reliable sources. Let's put it that way. So what is a reliable source? Medicare.gov. Oh my God, that's a good source. Medicare.gov. They are unbiased. I'd say they're a little bit biased towards Medicare Advantage, but it's pretty minimal. They're unbiased. They're really accurate, really accurate. You can do easy side-by-side comparisons of all the different options that you have. If you're not computer friendly, if you don't, they find that kind of decision a little bit too tough, then you can just call them at the real phone number, 1-800-Medicare. It's not a hard number to remember, 1-800-Medicare. If you want to call Medicare, you can go to Medicare.gov or Google Medicare and go to the US website, and they'll give you the phone number, or just try to remember 1-800-Medicare, and they will walk you through it. All of the other websites and phone numbers are malarkey, and have vested interests in misleading you. Or here in Missouri, as in most states, there's a state health insurance assistance program that's funded by the federal government, but it's more state specific. It's Missouri SHIP, SHIP, Missouri SHIP. Missouri State Health Insurance Assistance Program. You can go to MissouriShip.org. It's really spectacular too. Federally funded, nonprofit, free, unbiased, confidential, and they don't sell your information. They don't share your information. They don't do anything of the sort. So all this is to say, I think there's a decision to make. It's not a slam dunk. There's pros and cons. And Consumers Council's mission is to help you make an informed decision so that you know what you're deciding. Last thing, and then we can open to questions, is if you like this, if you think this is useful, if you want to help Consumers Council do more things like this free event, come to our fundraiser. We need to do that. That's how we survive, is with our fundraisers. So this one's going to be a particularly good one. It's October 29th. If you have a phone, you can pick it up and point at your camera at that QR code that I put up there, and it'll immediately take you to the site to register, or just go to MissouriConsumers.org, our organization's website where you signed up for this thing, and register. And this particular one is going to be really fun. Joyce Armstrong, who, as you heard, is one of the original founders of Consumers Council, and was formerly the executive director of Missouri ACLU. I think I got that right, Joyce? Yeah. Thank you. Yeah, was formerly so she's like a human amazing tower of strength and power. So she's retiring from Consumers Council board after all these years, and to sort of celebrate and honor that, another Consumer Council former board member, Ray Hartman, is going to be honoring her and interviewing her. Ray from all sorts of things, including being the founder of Riverfront Times, and he's got a frequent radio show, and he's a co-founding panelist of Donnybrook. And we'll try to get you a little bit inebriated and a little bit fed, and come on and join us. It'll be a lot of fun. And I think we have time for, hang on for 1 second.
Thanks, Ed. And I do encourage you all to go to our website, which is moconsumers.org. We have a new website. If you try to do this through the QR code, I hope it works, but we had some last minute glitches today with the website, and there have been just a couple of small changes. So, but it's on the website, moconsumers.org, and please just check it out. We're very proud of it. I do need to bring it up to date, but it really does a good job of explaining what we're all about. And as Ed mentioned, we are dependent on contributions from our community. We receive a large part of our funding from Missouri Foundation for Health, which we're very, very grateful for. But we can't exist without the support of the community. So please consider supporting us. Ed, would you like me to go through some of the questions? And Arthur Friedland has asked, while you were answering the questions, could you put up the comparison grid again? But the first question is, oops, hold on just a second. I just lost the chat. There we go. What happens to Medicare Advantage people after the U.S. switches to a single payer system?
I like that question. It makes the assumption that yes, we're going to succeed. We're going to get to single payer. So I like the question. So the beneficiaries that are in Medicare Advantage come out really ahead under single payer, because the benefit design in single payer is phenomenally better than the benefit design in Medicare Advantage companies. So the benefits get richer, the copays disappear, the co-insurance, all that stuff disappears, the deductible disappears, and the utilization nightmares, the getting permission, the prior authorization, and all that stuff, that's outlawed. It's outlawed. It's in there's a bill in the House and in the Senate, which would establish a single payer Medicare for all bill. They're actually more popular every time we put it in. The bill this year has more original co-sponsors than the bill last time did, than the bill before. So we're making real headway on this. And the people that are in Medicare Advantage or in traditional Medicare come out really ahead under this program. It's a much better program than what they've got today.
Okay, the next question from Diane is, are 5-star Medicare Advantage plans any better than the others?
Well, that's a good question. You would think that, I mean, right? Medicare is proud of the fact that they have this system for measuring the quality of Medicare Advantage firms, because we've all said, hey, how do we tell the good ones from the bad ones? So they've developed over the years this system of stars, where 1 star would be a terrible plan, and 5 stars would be the best plans. Um, those are those are almost meaningless. That's been looked at many times they mean exactly what they mean, right? There's a series of specific measures that Medicare uses to decide how many stars to give a plan, and it's an open book test, right? So the Medicare Advantage plans perform in a way that gets them to score well on those measures, and they do that because they get higher payments from Medicare if they have 5 stars. 4 star plans get more than the average, and 4.5 stars get better, and 5 star plans get a bigger monthly payment from Medicare. So they play to the test. But it's been looked at. Well, so what does that mean? Turns out that means nothing in terms of health outcomes. It means nothing in terms of actually, whether you can get into the care you want. There's no correlation between the star ratings and anything that's actually health outcomes related. So and that's not just me. I mean, that's like a millions people. MedPAC, the organization that guides Congress, the Medicare Payment Advisory Committee, I think it's called. Congress set it up, and they've said that this star rating is of really no value on picking a plan. So, and it's really relevant around here, us in St. Louis area, where there's one Medicare Advantage firm that I've seen a bunch of ads saying we have the top rating of quality from Medicare. Sounds really great until you realize that the top rating of quality from Medicare means nothing. It doesn't tell you anything about what you would want to know.
Thanks, Ed. The next question from Greg is, are all drugs covered under Part D?
Under Part D? No. So, the Part D drug benefit, well, first of all, none of the injectables that are given in an infusion, those kinds of drugs, or drugs in a hospital, those all go through Part B, as in boy, not Part D as in drug. But that's probably not what you're asking. I think you're asking more about the regular pills and stuff that you take and you pick up at the retail pharmacy and that kind of drug. And remember that when the Medicare drug benefit was enacted, it was set up not to be run by the federal government, but to be run by independent, typically for-profit companies, like Express Scripts, where I used to work, or Humana does their own, or it's done by them, and they get to decide their own drug lists. So the federal government puts certain parameters around that. They've got to cover, 2 drugs from this category. They've got to cover something from this category. They've got to cover for all the drugs from this category. They put some boundaries around it, but the Medicare Advantage firms are able to, or the Part D drug benefit companies are able to really alter what they do. And they can really take advantage of the tiers in the drug benefit. So a lot of times you'll see people that have the more expensive drugs, those conditions that require more expensive drugs, their drugs will be in a more expensive tier where you'll have to pay more to get them. And that's because the insurance company doesn't want the people that have to get those more expensive drugs. They tend to be sick. I don't want them. So no, they're different, and they can change that mid-cycle. So you can sign up for it and be told that your drug is going to be covered, and then 3 months later find out, no, it's not. And you have no recourse because that's the product that's being sold to you.
Thanks. Are there any other questions? I have one. And I just wonder, Ed, how you got involved in this, and obviously you're passionate about it. Can you tell people why you feel so strongly about this?
Yeah, I guess I've always been kind of interested in it. When I saw, even when I was younger, when I was a kid, and I saw some sort of screwed up things happening. But where I really started to get focused on this was when I was practicing, frankly, and I would see people who couldn't get healthcare. I mean, it would drive me crazy. I would somebody 64-and-a-half-year-old who came into the office and said, well, 5 days ago or 4 days ago, for about 2 hours, I couldn't move my left arm and it was numb. And I was a little worried about that. Was this a stroke? I was a little worried, but it went away after a couple hours. And I knew I had an appointment to see you, here 4 days later. So I thought I would, talk to you about it. And I examined her, and there was, no signs of a neurologic impairment at that point, but her neck had the sound that you can hear as a doctor when it sounds like an artery is blocked. So I thought, oh my gosh, this is like really real. There's had a temporary neurologic deficit. She's got what sounds like a vascular obstruction in her neck. We need to get this imaged, and probably get some kind of procedure done because she's an impending time bomb of a stroke. And I said, and I explained all this to her. I said, we got to do something here. This is like, I wish you'd come in 4 days ago. I'm scared for you. Something's going to happen. And she said, well, what's it going to cost? And we kind of came up with a ballpark of a few $1,000. And she, well, I can't do that. She said, I can't do that. She said, I'm 64 and a half. She said, I'm going to pray and wait until I'm 65, and then I have Medicare, and we can get this taken care of. And it's a happy ending story. Praying and waiting, for whatever reason, worked. And at 65, she got her study. She did have a blockage. She got it repaired, and she didn't have a stroke. Hooray! So good happy ending. But you see people like that, and then you go into the next one whose diabetes is out of control. You saw him last month, and you gave him a prescription for insulin, take twice a day, and you see him today, and he's not any better. And you ask him why, or I ask him why, and he says, "Well, I can't afford that much insulin. I'm taking it, a little bit every other day. I'm not taking it twice a day, like you said." Going, see people whose kidneys are like deteriorating in front of you because they can't get the medication to treat their hypertension, and then they'll deteriorate to the point that they're on kidney failure, and then they'll have Medicare and we'll pay for that. And that's anyway, these kinds of stories over and over and over again made me realize that the commercial insurance industry is not going to solve this, and we need to just give everybody. We all want the same thing. We all want our health. We all want to see the doctor in hospital when we need to, and not to go bankrupt to stay healthy. We all want that. So let's get it.
Yeah, I agree. Rick has his hand raised.
Hey, Rick, haven't seen you in a while. You're muted, Rick.
Oh,
you're on mute. Nobody mutes Rick LaMonica.
Oh, hold on.
There you go.
Now you can hear. Thanks for putting that up. I didn't. I forget that my sound's off. How do we register for the fundraiser on the 29th?
Go to, I put it in the chat. It's www.moconsumers with an S on it.org. Or if you Google Consumers Council of Missouri, you'll find us. Or if you'd just like to give me your email, send it to me in the chat. I can send you some information regarding the fundraiser.
Well, I caught some of the stuff now. I know where it is. I have to go.
Okay, good.
But I'll go on and register. And
wonderful. Wonderful. Thank you. Thanks,
you. Rick. It'll be good to see you.
I have to mute. How do I do that?
I can do it. There you go. You got it. Okay. Are there any other questions as we wrap up? Oh, well, Greg asked, will we ever see single payer?
Yes. Any major social change seems impossible 2 years before it's accomplished. Passing Clean Air Act. Well, we all want clean air, but you want to spend the money retooling that. Our factories will go out of business if we require that. Americans with disability. Well, we all want people to be able to come to work, but what it would cost to retool the sidewalk. It always seems, for financial reasons, insurmountable 2 years before, and then it's here, and we can't imagine life having been lived without it. So the bill, as I said, the one in the House has more. It's unfortunately a one-party bill at this point. We very much want it to be bipartisan, but it's been only Democrats that have signed on to it. But the Democrats in the House are fewer in number this session than they were last session. And despite it being fewer in number this session, there are more co-sponsors of the bill this time than there were last time, than there were the time before. So the bill is getting closer and closer to being enacted, and groups like ours have more robust strategies to make it happen rather than just pass the bill. We have a whole bunch of other things to make it happen. So it will. Whether it's 2 years off or more than that, I don't know. But it is coming. It's inevitable. We always do it. We will get there. Help us.
Okay, I think we have time for just one more question. And this is from Robin. What can we do to stop Medicare Advantage plans from advertising on TV?
Yeah, well, in some sense we can't, because just like we can't stop drug companies from advertising on TV. We can't because of the free speech. So we've sort of looked at that question specifically on the drug industry and decided that it would be a fool's errand to try to address those ads, because we would fail, and so we can't really stop them. We've thought about trying to advocate for putting in disclaimers, having some warnings, more of that. Those disclaimers have never been shown to be very effective and actually alter consumer behavior. So that would be I think another fool's errand. I think the way to stop the MA plans from advertising on TV is to put them out of business. Put them out of business.
Well, I know if there's anything that's possible, you will make it your mission in life to work toward that. Okay, well, with that, I think we're going to wrap it up. Thank you very much, Ed, for this presentation. I know I learned a lot. We will have it up on our website and also have it on our Facebook page too. So thank you all so much for coming. As we advertise this, we don't get anything out of this. We just want to be sure that you have good information when you make your decision. All right. Have a good evening, everyone.
Thanks for coming.
Bye-bye.
Thanks.